Good evening, ladies and gentlemen. It is a cold, rainy day out here in Johannesburg, and I understand
Sorry,
from my
because you don't
sister,
know my name. I have had my hand up. Thank
exactly
you
the
so much.
same out. Yep. I understand it's exactly the same out in Durban at the moment, that it's cold and rainy over there as well. So please keep warm. Make sure that you have something to eat this evening. We have a phenomenal discussion and presentation that will be delivered by Dr. Nevondo. I'll tell you a little bit more about him shortly. He's going to be covering the topic slipped capital femoral epiphysis. In fact, you're all going to love it because he is quite a speaker and he's quite somebody that's quite amenable and approachable, and you like his character, no doubt. And he is going to make sure that you're going to, as always, ask him to come back and return for further presentations, which he's happy to do. He already has three other topics that he's ready, including clubfoot and Perthes, which he just gave to me shortly a while ago. So just a few housekeeping rules. You will know that during the course of the presentation, your microphones as well as your videos will be disabled. And then during the course of the presentation, if you have any questions, please feel free to post them in the chat. So we will be able to respond to those either directly, and if there are questions that are aimed at Dr. Nevondo, Dr. Nevondo and I will go through those questions and you will answer. I'm sure he's got a lot of answers, and I've got the rest of the team in the background. Sister Nasisa, Neo, they could answer the others if Dr. Nevondo gets stuck. And I know that there are professors and nurses and teachers, and I understand there are some youngsters that are also joining us on this platform this evening. So welcome to all of you. Welcome to those of you that are outside of South Africa. So it seems like the Thursday webinars presented by the Clinix Health Group is increasingly becoming popular. So thank you so very much. It's been a number of years now since the presentations have been going on and being presented on Thursdays since around the COVID times. And due to popular demand, we've been keeping these sessions going. So for those of you that received the link or the invitation, you would have clicked on the link, you would have registered, you put your names, your surname, and all the information that comes with that, including your registration numbers. And so something's changed this time around. I know historically, if you registered and you did not register with an MP number, then you were finding it difficult, for instance, to enter your SANC number for instance, the nursing colleagues that are on the line. And so it was not able to pick up the number, but it does now. So please, you don't need to put your registration numbers in the chats. So you will automatically be receiving your certificates, your CPD points once you've registered. If somebody sent you a link and you didn't register, I ask that you please ask them to send you the link so that you can register and receive your CPD points. And as I said, while Dr. Nevondo is presenting, feel free to put your questions in the chats. And so towards the end, we will cover all of those different questions as far as we possibly can, time permitting. And then also importantly, if you would like to speak, raise your hand. We'll unmute your mic and you can ask and pose a question directly to Dr. Nevondo. As I mentioned, Dr. Nevondo is quite popular and as a speaker, and he's been on this platform before. And he's quite enjoyable as a person as well. And Dr. Lindelani Nevondo, he's actually a board certified orthopedic surgeon, and he's got a special interest in arthroplasty, particularly hip and knee replacements. He also manages a wide range of orthopedic trauma, arthroscopy, and hand surgical cases. Dr. Nevondo, well, he obtained his undergraduate medical degrees, this is the MBCHB, from the University of Pretoria in 1998. Dr. Nevondo, you were 4 years ahead of me rather. And then he went on to complete his specialist training in orthopedic surgery at Sifako Mahato Health Sciences University. qualifying in 2019, and both with FC Orthopedics as well as M-Med in Ortho. So he currently practices at 4 different Clinix Health Group hospitals across Gauteng, at the BEH Hospital, Bochelong in Bulweni, a private hospital in Vosloorus, at Naledi in Kanyeze Private Hospital in Sebokeng, and then Dr. S.K. Matseke Memorial Private Hospital in Diepkloof, Tepotemba Private Hospital in Dobsonville. So Dr. Nevondo is actually a founding member of LNS Orthopedics, which was established in 2021. So where he just continues to provide comprehensive, patient-centered orthopedic care with a focus on restoring mobility and improving quality of life. So Dr. Nevondo, as I said, I've been looking forward to this discussion. You gave me a heart attack when you told me that you were not ready and prepared, but the presentation, I understand, has been ready since last year. And we really thank you so much for giving us so much of your time. And ladies and gentlemen, just so you know, Dr. Navondo is still at the hospital and he's presenting from there. Actually, I was at the same hospital with him earlier today and he remained there. So thank you very much, Dr. Navonda. Welcome once again. We look forward to your presentation, and yeah, I'll be right here with you in the background. Thank you.
What did I do?
Yep, we still see your main slide, your opening slide.
Okay, can you still see it?
Yes, thanks, Dr. Navonda.
Okay. Thank you very much for the introduction, and thank you to everybody who has logged in just to listen to my presentation. To the Clinix group, thank you very much for the opportunity to actually just impart some knowledge to some people. And the topic I am presenting today, it's commonly called SUFE, but the correct word is actually slipped capital femoral epiphysis. And when you talk about slip capital femoral epiphysis, if you just quickly Google it, the common X-ray that comes out is this one of a bilateral pediatric patient with one-sided slip on the right side, and the left side that's not slip. So it actually gives you a view of what normal look like and what abnormal look like. There's one arrow. Okay. So just as introduction, SUFE is a hip dis. I'm going to call it SUFE because it's an easier word to pronounce than SCFE or SCAFE. So I'll call it SUFE most of the time, but the correct word is actually SCFE. SUFE is a hip disorder in adolescence. It's where the femoral head slips in relative to the neck or the neck of the proximal femur. It is one of the most common disorder in the age group, which is the adolescent age group, and it is important to get an early diagnosis, because an early diagnosis means early treatment, and early treatments means the patient gets better prognosis. If you just go and Google the word SUFE, simply, if you start on ChatGPT, which is one of the common things used these days, it says it's a slipped capital femoral epiphysis. It's a hip disorder in adolescence where the femoral head, which is the ball, it slips off the femoral neck through the growth plate. Not 100% correct, but it's very close. And if you go to Google says SUFE stands for slipped upper femoral epiphysis, which is a condition where the head of the thigh bone slips through the growth plate, primarily affecting adolescents. The difference with the two is that ChatGPT says the head that slips, whereas Google says it's the thigh bone that slips. And the second part is actually true. So Google is more correct. And there are many names that are given to this disease. SUFE is the common names that is used because it's actually easy to pronounce. It says slipped upper femoral epiphysis. And then SCF is slipped capital femoral epiphysis. Some people call it Coxavara adolescentium, which is not a commonly used word. So the word SUFE itself, maybe the one problem with the word SUFE will be the fact that if you look at the proximal femur, it has two epiphyses. One is the one on the head, and the other one is on the greater trochanter. So if you just say slipped upper femoral, you might be meaning the one on the greater trochanter, which is not SUFE, but it's closed. When you say slipped capital femoral epiphysis, now you're saying is the epiphysis on the head. It's not just on the proximal femur, it's on the head. So the word SCF is more correct. The word Coxavara adolescentium, it's also a bit misleading because there are other conditions that can cause Coxavara in adolescents. But the word are usually used, those words or those definitions are usually used interchangeably. So before we go deep into the condition itself, we just need to remember a bit of anatomy of the patient, especially anatomy of an adolescent. So the hip joint itself, we know it's a ball and socket joint where there's the femoral head has an epiphysis, and that epiphysis sits in the acetabulum. The growth plate or the physis is the weakest point in an adolescent, and SUFE occurs through the physis or the growth plate. So here's a picture that shows the head of the proximal femur, where you can see the head, you can see the neck, you can see the greater trochanter, the intertrochanteric line, and the lesser trochanter, and then the body or the shaft. This is more on an adult patient. And when you look at that, you can also see the blood supply that goes to the femoral head. There's the medial circumflexor femoral artery, which supplies the head of the femur and also the greater trochanter, but we're interested in the head of femur, where it goes subcapsular in this region and goes to the head. So if any condition happen in this area, it affects the blood supply and the head can die. So when you look at a pediatric proximal femur, you see that is the epiphysis that we are talking about. And that will be the physis, which is the growth plate or the physial plate. And this is the metaphyseal area, which you can call the femoral neck. That's your greater and your lesser trochanter and the shaft. So when a child is growing, or when a person is still growing, like still skeletal, immature, the growth happened in the bone. It happened in both proximal and distal part. Like in the proximal humerus, 7 millimeter of growth happened in the proximal humerus, whereas 2 millimeter happened in the distal humerus. So if you have to have an injury of a growth plate in a humerus, the one you can choose is on the distal humerus, because then the limb length discrepancy will be less. And the one we're interested in this case is on the proximal femur. So 3.5 millimeter of the femoral growth happened, which is 30%. It happened on the proximal femur, whereas 9 millimeter happened on the distal. So when you have an injury or a SUFE or a PERFID or a DDH happening in the proximal femur, LLD is common, but it's not as severe as when it happened in the distal femur, luckily in this case. So I said the condition happened in the growth plate or in the physis. The growth plate is histologically, it's got many stages. There's the resting stage, where there's metric production. The cells are metabolically inactive. They don't replicate, or they don't undergo mitosis. Then there's the growth or proliferation stage, where they now go under mitosis and they increase in number. And then there's the hypertrophic zone, where the cells increase in size. So the cells become very big. And if you can look at the histological slide I inserted there, you can see the cells are actually quite big. The white means the cells are actually starting to calcify. But this hypertrophic zone is where majority of the problem happen, because the cells are so big that they are not as strong as in the other zones. So most of in fact, SUFE happen in the hypertrophic zone. And even the Salter Harris injuries, the injuries of the growth plate in children, it happened in that zone. So in that zone, the hypertrophic zone, the cells are hypertrophic, or the chondrocytes are hypertrophic, they're enlarged, and they're in different stage of maturation. Then after that, they will actually calcify and die and become bone. So what causes SUFE, and what are the risk factors, and what is the epidemiology around it? The cause, if you just put it simply, is when you are loading the physis beyond its tolerance. So what can cause the physis to have low tolerance or it to be weak? It's usually in pre-adolescence or in adolescence where they are in a growth spurt. So the cells are actually rapidly growing. The load that is loaded is actually obesity majority of the time. And then trauma can also be the load. There are other things that are risk factors to this. Obesity is the number one known biggest risk factors. The other risk factors is patients who have undergone radiation therapy affecting their growth plate, patient with acetabulum retroversion, where the acetabulum is like kind of facing back, or patient with femoral anteversion, where the femur is facing forward, because that discrepancy means now the head is under stress and it can lead to the epiphysis leaping. And then you have endocrine disorders, commonly your hypothyroidism, your growth hormone deficiency, and your kidney are known to cause or are known as risk factors for patients to develop SUFE. There are many of those endocrine conditions that you can do, and it is important to exclude them before treatment is taken upon. So in terms of epidemiology, this disease commonly affect more males than female at a ratio of 2 to 1.4. They did a study in America, and they found that the people who were affected more were African Americans, the Pacific Islanders, and the Latinos. And then LODA did a study where they checked the age, and they found that the average in boys is usually 12 to 13 years, and in girls it's almost a year earlier, which is 11.2 to 12.2 years, where the disease is common. And then the side that is commonly affected is the left hip. And then in about 17 to 50%, the condition happened bilaterally with an average of 25%. In the diagram that I added there, it shows the age of diagnosis of slipped capital femoral epiphysis. You can see around 14, 13 is the age where the disease commonly happened, whether it's the idiopathic or is the atypical one. So there are some studies that were done which support the previous statement. This statement is supported by this. So from this journal, there was a study done by LODA, who's one of the great researcher or the great treater of SUFE. So the conclusion to that study, which was done in 2011, was that around 0.33 to 24.58 in 100,000 children will develop the disease. And the age was between 8 to 15 years, where they put an average of 12 years for boys and 11.2 for girls. And then the age group when they did the study was it was more frequent in Caucasians, Pauline, don't even know what that is. And then in blacks, which is the African Americans, and then Hispanics or the Latinos. And bilateral was 18 to 50% with an average of 25%. The one I showed before was saying 17 to 50%. So it's more or less the same. And they did say something about obesity also in the patients that develop this disease. So what clinical presentation do you expect from this patients? The important part about this is majority of people that are going to see these patients are going to be the first liners. It's either the patients go to a physiotherapist because they say the child is limping and they need some physiotherapy, or the child goes to a doctor, usually a GP, or they go into a casualty, or they are seen in clinics. It's important not to miss this. Usually the child you can see when they come in, it's a chubby child who is either limping or refusing to bear weight with pain on the hip. So the history that they give, they might, it's not always there. They might give a history of trauma. The child was playing soccer and then he fell. They might complain of pain. It's not always there. But when they complain of pain, it's either pain on the hip, pain on the thigh, or pain on the knee. The pain on the thigh and knee is usually due to the stretching of the obturator nerve. The patient usually complain of a limp. They've inability to bear weight, and they might have a limb deformity, and they might have a leg length discrepancy. When you examine them, the easier way for orthopedics to examine patient, if you don't want to miss anything, is to just go back to the basics and do the look, feel, and move. So when you look at them, they will have an abnormal gait or not able to bear weight, and the limb might be malaligned. Usually it will be externally rotated, and they might have atrophy of the thigh muscles if it's a chronic SUFE. When you examine them, when you palpate them, they will have tenderness, and the tenderness is on the groin. Though the patient might come complaining of pain on the thigh and the knee, when you examine them, the pain is usually in the groin. The pain on the knee and thigh is usually referred pain. When you do neurological examination in patient with SUFE, majority of the time it's usually normal. And then when you do the move, the hip range of motion is usually reduced. And then there's something called the Drenman sign. When you flex the hip, it obligatory goes into externally rotation. I think I have a picture for it. Okay, before that picture, this is a patient. When you're just looking at this picture, this side, which is the right side, the leg is sitting straight. This is the normal leg. When you look at the other leg, it's externally rotated and it's actually shorter. So this is the shorter externally rotated leg. The Drenman sign, which is the obligatory external rotation when you flex the hip, you can see this hip they were flexing the hip, and you can see the leg is going into external rotation. You can also see it in this physiotherapy examination that the hip is going into external rotation on flexion. Oops. So once you have suspected that the patient has got SUFE, then there are investigations that you have to do. And if you are in a rural area, a place where resources are limited and you can only do one investigation, the investigation of choice will and always be an X-ray. And then AP and a lateral X-ray can tell you a lot of stories. So the views that are done commonly is your lateral, your AP, and your frog lateral X-ray. Your lateral X-ray will identify the subtle slip. Your frog lateral, I'm going to talk about it just now. But when you've done the X-ray, there are some specific things that you look for. And quick Google can actually give you the answer, and you can draw this line yourself with ease. You get something called the Trenthorn sign, which you draw a clear line. I'll show you just now. And then you got blurring of your proximal femoral epiphysis, a metaphysis. So your epiphysis is slipped and usually slipped to the back. When it's slipping at the back, when you look at the metaphysis, it's actually blurred. You have your Sarum sign and your Capenas sign, and you have your still metaphyseal blank sign, and you have a growth plate widening. Okay, those too many words. So this is an X-ray showing a patient with SUFE on the side. If we just start by talking about this side, you can see this is your epiphysis, and this is your neck, and this is your shaft. You can see the epiphysis is sitting in the acetabulum, and the neck or the metaphyseal is sitting relatively aligned to the epiphysis. When you look at this side, you can see the metaphyseal have moved out. Hence, I was saying slipped upper femoral epiphysis. is not as correct as it's supposed to be, because it means that the epiphysis is the one that is slipped. But in this case, when you look at it, you can see the metaphysis, the proximal femur, is actually the one that has slipped out of the epiphysis. So this is an AP X-ray. When you do a lateral X-ray, you, like I said in the picture before, you can see the subtle slip that is usually missed on the AP X-ray. And if you just do a diagram to show the Trenthowen sign or the Klein, you draw a Klein line. So you draw a line through straight on the neck or on the metaphyseal area. That line must bisect about 1/3 of the femoral epiphysis. If it does not, then it's a positive sign. It means this head has actually slipped. And when you look at it on X-ray straight, so that's your epiphysis. Okay, before that's your epiphysis, and that's the Klein's line. You can see the Klein's line bisecting the epiphysis. And when you look on the other side, the line is not bisecting the epiphysis. And then there's something called the metaphyseal blank sign. Like I said, this, if you just take a quick look at this, you might actually say, your Klein's line is actually normal. The epiphysis is sitting there. But when you look, if you look at this area, you can see it's actually more white, or it's more blurred, because the epiphysis actually slipped to the back of it. This is called the metaphyseal blank sign or the steel sign. So this blurring of the proximal femur metaphysis due to the posteriorly displaced epiphysis. This will also still be on the AP X-ray. There's something called a sham sign. In a normal femur that is not slipped, there's a triangle that you see on the inferior part of the metaphysia. It's usually obscured or distorted when the patient has a slip. So that's X-ray. So X-ray gives you all those clues about, and you can actually make a diagnosis. Majority of the time, we hardly go into other investigations to diagnose SUFE. X-ray is sufficient. But MRI can also give you a clue, because what happened sometimes is the patient get a slip, they come to the hospital, they go to X-ray position them, trying to do a frog lateral, and the slip reduces. When they do the X-ray, they come to you, the X-ray is normal, but the patient has the pain. And if you suspect it, and you're still worried, you can do an MRI. And when you do an MRI, you can see the MRI might help you find a pre-slip. It might help you can see a growth plate widening, and you can also see edema. So when your X-ray is inconclusive, you actually do an MRI. You can see on this one, there's the epiphysis and there's the growth plate. Growth plate in this side is actually widened, so that you can diagnose on MRI. CT scan and sonar. CT scan is just like a better X-ray, but it doesn't necessarily add much value. You can measure the angles better on a CT scan, but it's too much of a kill, and it's too much radiation to get the same information. And the sonar does not really add much value to diagnosing or to management of SUFE or slipped capital femoral epiphysis. So once you've done your investigation and you have examined the patient, you have suspected, you have examined, you've done the investigation, and you're sure, you're convinced, you had made the diagnosis that this is SUFE, then you have to classify it. Classification helps you with agency. When should you treat the disease? It helps you with what kind of management should you undergo. It helps you with what might be the prognosis of the disease. So there are many classifications that has been done for SUFE. The guy who did a lot of work on SUFE is Lauder. There's the morphological classification, temporal classification, there's the Southwick classification, there's where you classify it according to whether it has a femoral acetabulum impingement phi, whether it's a chem or a My slide is gone. Okay. It's back. So you can classify according to morphological, temporal, Lauder, Southwick, whether there's impingement or not. And just going through this. So your morphological classification, this one is based on an AP and a lateral X-ray. So it shows you how much the head has, the epiphysis has slipped, or how much the metaphysis has slipped over the femoral, over the epiphysis. So if in a pre-slip, there's widening of the physis, but there's no displacement, this is the one that mostly, or you will diagnose via an MRI. A mild slip is when it has slipped about 1/3 or up to 30% of the head is tilted. And a moderate is when 1/3 to half of the displacement, 30 to 60% in degrees of slippage. When it's more than half displaced, then you have a severe slip, and it goes with your management. A severe slip will need acute, a severe and moderate will need treatment now. And if you put it in a diagrammatic form, you can see this is where either it's a pre-slip or it's normal. You can see when this 1/3 slip, and then this one has almost totally loptosed. And you can see also on lateral X-ray the grading of the slip. So this is mild, moderate, severe. And then Lauder classification, this one is based on the ability to bear weight. So it's a very simple one. It actually helps you in assessing the stability and the prognosis. So a stable one is when the patient is able to bear weight, whether they're using crutches or they are not using crutches, as long as they're able to bear weight. And it gives you prognosis because usually when the patient is able to bear weight, their chances of getting a vascular necrosis later is about 10%. An unstable one, whether they are using crutches or they are not able to bear weight on the limb, and usually it will be externally rotated with reduced range of motion. And in this case, they have a 50% chance of getting avian, especially if nothing is done on the patient. Temporal classification is based on the symptoms. It actually gives you a guide to when should you act on this patient. You have acute, chronic, and then you have acute on chronic. Your acute is when the symptoms are less than 3 weeks. This is the one where the patient comes, you suspect it, that patient must immediately be taken off their, they must not bear weight, they must be taken off their feet. So there's a patient that either you give crutches or you put them on street bed rest at the same time, and then they can be investigated, sent to x-rays, but they literally admit at the same time, and they should be taken to theater sooner than later. The chronic one is when it's more than 3 weeks. This one will usually present as acute on chronic, actually. They will give you a history that they have had the pain and then now they have a severe pain. This is the one where you can give crutches and send them to x-ray because they're usually able to bear weight because they've had the disease for a long time. But if it's acute on chronic, they usually behave like an acute. And it's difficult to differentiate between acute on chronic and acute if you don't have the history per se. The other classification that's there is the Southwick classification, which measures the epiphyseal, diaphyseal slip angle. So this is based on a frog lateral X-ray or an AP X-ray. It measures the severity of the slip. So it's more or less not so different from your morphological classification. And this one, to measure it, you actually draw a line. First, you draw a line at the edges of your epiphysis, the distal edges of your epiphysis. Then you draw a line perpendicular to that line. Then you draw a line straight through the neck. Then you measure that angle. If it's less than 30 degrees, it's a mild disease. If it's 30 to 60, that's moderate, and more than 60 is severe. So you can see this one, it's a moderate because the angle now is 40 degrees, whereas this one is 12 degrees, so it's mild. And if you have an X-ray, this is how you actually do it. You draw a line at the distal edges of your epiphysis. You draw a perpendicular line to that, and you draw a line through the neck, and then you measure the angle there. In this case, maybe 15 degrees, so this is mild. And then on the other side, you draw that line, you draw a line through the neck, and you draw a line perpendicular to that, and you can see the angle has increased, probably 30 or plus. So this might be a mild disease. So you've made your diagnosis, you have classified it. The next part of it is, if it's not SUFE, what else can it be? Because there are a few conditions that might look the same, but they are the treatment is very different. So the conditions that are commonly talked about when you talk of pediatric HIV condition, the three top conditions is your Epiphysis, and then it's your SUFE, and then DDH. Your Epiphysis is usually when you have loss of blood supply to the femoral head. It's in younger children. So it's usually younger, and mostly it's unilateral. Whereas your DDH is common in newborns. So these ones are like 10 or so years, whereas in SUFE is about 12 and a half or 13 years. And DDH is in newborn. This is when you have abnormal development of the hip, which lead to dislocation. So if the femoral head does not sit inside the acetabulum does not develop. So when you have a dislocation, you need to reduce it quickly because now the acetabulum will not develop, and then you will have severe DDH. Other condition that might mimic this is your transient synovitis. It might be septic arthritis, might be femoral neck fracture, which is very difficult to differentiate femoral neck fracture to SUFE. In fact, it might as well be the same thing, and the treatment is pretty much the same. And if you just put it in a diagrammatic form, DDH, it happened at birth, and it's usually in children who are born as bridge, and it's usually first born girl. And it's the test that you do is your Ballot test and your Otolani test, where you're either dislocating or you're reducing in those children. And then your leg calvopathy disease, it's usually happening in 4 to 10 years. It's usually short boys with delayed bone age. They're usually short and not big like the ones in SUFE. So this one's short delayed, and they usually have knee, groin, and they limp. So the presentation is this of Perth is more or less the same as the one of SUFE. And SUFE, like I said, 9 to 13 years, overweight, male teenagers, knee, thigh, groin pain, and treatment is usually surgical. The first two, the treatment is usually non-surgical, but in SUFE, the treatment is mostly surgical. And when you look at the X-ray, you can see this is a normal located hip. This is a dislocated hip. When you look at this, you can see the epiphysis there. When you look at this, you can see the epiphysis is actually fragmented. So this is Epiphysis, this is DDH. And this one you can see, this is a normal hip, and this one on this side has slipped. So this is the one we've been talking about all along. So how do you manage this condition? There's many things about management, but the important part is this is an agent condition. You need to actually do surgical fixation quickly because you need to avoid further sleep, and you need to avoid weight bearing. So the aim of the management is to stabilize the sleep and prevent progression. And controversially, you have to consider prophylactically fixing the other hip that doesn't have a slip. I'll just show some studies about that soon. Is there a role of non-surgical treatment in SUFE? Not much, very little. So the part where you're doing weight management and you're doing non-weight bearing, those are adjuncts still to surgical treatment. And you also have to do endocrine conditions. So you have to take bloods and diagnose some endocrine and manage those endocrine conditions. But this is not necessarily saying you don't do surgical treatment. But again, surgical treatment goes with both the patient's parents and many other factors. Maybe the patient have conditions where they cannot be operated, or the patients just flatly don't want to be operated. I mean, the parents. So in that case, in the patient that cannot be operated, usually they are put on skin traction, and it can be a long time, up to 12 weeks. And then after that, you put them on crutches and you ask them not to weight bear for some time. In younger patients that cannot be operated, you can put them on spica cast. Problem with this, it has a very high rate of causing AVN. Spica is usually used in DDH, not in Epiphysis. Not in SUFE, sorry. So treatment of SUFE is mostly surgical. And the options that you have in surgical is percutaneous pinning or percutaneous in situ pinning. Whether you do both sides or you do contralateral pinning preventative, it's again very controversial. And then you have open epiphyseal reduction and fixation. Capsulotomy, they say it's if you can't reduce it and you do capsulotomy, it's good because it actually reduces the pressure inside the hip, and it might spontaneously reduce after doing capsulotomy. But majority of the time, the reduction actually happens when you're busy positioning the patient on the bed, on the surgical bed. So this is just a flow diagram showing what you can do. So if you have an acute unstable, you attempt a gentle close reduction, usually if the slip angle is less than 30. Once it's reduced, then you pin it. If you are unsuccessful, you might have to do capsulotomy, you might have to go to surgical opening and dislocation and fixing. If your slip angle is mild, you again try in situ pinning. If it's moderate or it's severe, usually, and it's not reducing, that's where you're gonna go for surgical correction. This is not simple procedures. They have a very high learning curve. So percutaneous pinning, I guess that was supposed to be pinning. Indication is for stable SUFE or the ones that spontaneously reduce. They often reduce during positioning on a theater table. The aim is to stabilize and prevent further slips. And what you do is you put screws on the lateral side through your neck into the epiphysis. Now, there's many talks about whether you use a single screw or 2 screws, and some people even go as far as using 3 screws. So a single screw has good outcome with a 10% chance of slippage. 2 screws are more stable, especially for rotational forces. Problem with 2 screws is you are dealing with a child and the space is little, and you are likely to violate the capsule, or you are likely to violate the cartilage, and then that has got its own consequences. So single screw usually is good, but if you can do 2, this is an example of a single screw fixation. So usually you aim to have either 2 or 3 threads into the epiphysis. And you can see this is an example of the threads that are in the epiphysis. The epiphysis start there. In this case, I think they go 3 or 4. But you don't want to go past your cartilage and get into the hip joint, because that will be disaster also. An example of a single screw percutaneous fixation, you can see the still space between the screw and the cartilage, and the screw is nicely in, about 4 so screw threads have gone in. This is the patient that spontaneously reduced, and in this case, this was a severe sleep, and this doctor decided they need to put 2 screws. Good results. Yeah. So a study done in 2006 is in the Journal of Pediatric Orthopedics, where they were checking the biomechanical stability of single screws versus 2 screws fixation. And their conclusion, they said, the data supports the use of 2 screws construct in unstable fixation, and the biomechanical benefit of 2 screws need to be considered in the face of greater potential of advent penetration of the joint. So 2 screws are good, but you have a higher chance of causing problems. And in majority of the time, we just doing 1 screw, and the results are actually good. I am yet to do 2 screws in SUFE. I always do 1, and I'm yet to get a secondary slip anyway. So contralateral pinning, or call it controversial pinning, is when it's indicated in patients that are young in presentation. So a patient who gets SUFE at an early age, before 10 years, remember the average age is 12 somewhere. Those who get it early, usually you will pin them because they are likely to dislocate the other side. Those who have endocrine disorders, those who are obese with delayed presentation, and patient with open triradiate ligament, these are the patients that you likely to do contralateral pinning. And they do say it's controversial. So this study on the JBJS, Journal of Bone and Journal of Surgeon, it says, which was in, I don't remember the year, but in this study, they were checking the rate and risk of contralateral slippage in adolescents treated with slippage, in adolescents treated for SUFE. And the conclusion they're saying on this study, the patient that you need to do contralateral pinning is younger patients with hypothyroidism, patient with severe obesity, patient with low vitamin D, patient with diabetes mellitus. So it's patients that have a higher risk of sleeping on the other side. Is the patient that you do the study on. So this is an example of a patient that has had both sides pinned. This side, as you can see, this widening of that epiphysis. So this is the side that was having SUFE, and it reduced and then it was pinned. This side, the epiphysis still looked normal, but it was pinned prophylactically. Now, if the patients present late, acute on chronic usually, if the patient have a severe sleep, that is not reducing. If a patient have a severe unstable sleep, those are the patients that you will consider doing open reduction and internal fixation. The procedure that's done is called a modified Dunn procedure. So you have to actually put the patient on lateral decubitus position, and you have to cut laterally and then dislocate the hip, and then you have to debride the metaphyseal area, reduce, and you can either fix with either K-wires or with screws. These have a very high learning curve, but in patients that have severe sleep, it actually has better results. And this is a study that was done. It is on the BMC, musculoskeletal disorders, and they were checking surgical treatment of sleep of SUFE by Dunn procedure and modified by GANs. And the conclusion to it is that the Dunn osteotomy modified by GANs should be preferred, or should be the preferred method in treatment in patient to treat moderate to severe. So for your mild, you can still go. For the ones that reduce, you can still pin. But for moderate and severe SUFE and late presenting obese, usually you will end up doing the modified Dunn procedure. And just putting a diagram to it, this is the Dunn where the patient has slipped, so the osteotomy is done in this area to reduce this, and you put a soft tissue flap to cover. So this is the patient that had a severe slip. This patient had actually healed. Like the condition is actually, this is now just become one. And they did a osteotomy on the neck. Good part about this is it's actually more almost intertrochanteric. The blood supply is actually less compromised in this. They do an osteotomy, it's a corrective osteotomy. In this one, they actually move further away from this is the Southwick and in Hamslow. This is where they move further away from the head and they do an osteotomy on the subtrochanteric area. So this osteotomy is actually a closing wedge of osteotomy. Also, this one is a closing wedge osteotomy. So complications of SUFE and complication of SUFE and its treatment, they are vast. If nothing is done, or even when sometimes when something is done, you can have your sleep progression where it goes from mild and it progresses all the way to severe. Again, you can get avascular necrosis where that if it's a severe on its own, it can cause avascular necrosis. The treatment also can cause avascular necrosis. So even when you're doing a percutaneous treating, they say you have to do gentle reduction. If gentle reduction doesn't work, you have to open. There's contralateral SUFE where you get now. It was on one side and it goes to the other side. Hence the controversy of whether you pin both sides. And then you can get chondrolysis, which can be due to the SUFE itself, or it can be due to the procedure done when you're doing the pinning. If your pin goes past the cartilage, you get chondrolysis. The patient usually get chronic pain if nothing is done. And once you're opening any patients, you are left with a chance of getting arthritis, septic arthritis, which is infection. And then the patient can also get degenerative arthritis because of the condition itself, or because of the procedure because of the procedure that was done. Okay, we fly away. So conclusion, in terms of SUFE. SUFE is a serious condition which require early diagnosis and it require early management. The most important thing you can do on this patient is to send them to do an X-ray. And once you suspect, or once you have diagnosed it, take this patient off their feet. So either they get crutches or they bedridden and they must be admitted. A prompt or an agent surgical treatment, usually pinning, which is the most common done procedure. It reduces and prevents the complication, which is the most dreaded one, is avascular necrosis. This is a few places where I got the information from. Thank you.
Wow, that was remarkable. So much, Dr. Nevondo. Wow. And I knew you did say you've been working so closely with patients that are affected by PERDs and, with the club feet, DDH, you were talking about that. And the fact is, Dr. Nevondo, you made it so clear. You gave us images. So I can see you put a lot of time into it. So thank you for that. And then also supporting treatment, and you said some of the controversial components or management of SUFE. You're bringing in research to show that, why it is justified. So the time and effort and the energy, thank you so much for putting the effort into it. I think for many of us and about that are on the line, and maybe those that are not so familiar with a lot of the terms, you made it quite clear. So thank you for making it really practical. And even the presentation of the patients, because you're talking about how a child comes limping repeatedly, and you're just not getting to the bottom of it. So that really is really helpful, especially in in a general practice environment, a clinic environment, and you kind of know what to look for. Just as an opening question, how common are you seeing this where patients are actually being referred to you specifically because it was picked up at at the primary care level, and then, or is it just after there's some level of complication already? In other words, are we underdiagnosing these when patients come to us?
You know what? I think I'll give the primary people, the GPs, the nurses, and people who see the patient first, I'll give them props. They're actually doing very well, because the most important thing you can do for a patient with SUFE is to send them for X-ray. If you get an X-ray with a report, it's almost always the radiologist will pick it up. So usually when you get the patient, when they referred, they literally come with a diagnosis. The patient has SUFE because the radiologist has already reported them. So they're not as missed as before. The problem that happens is when people treat the pain, or people want to treat the limb without radiological investigation. So if I have to give one simple advice, is any child that is limping with a hip pain need an X-ray. It's then the rest usually just follows.
So the like you said, even if it's in a resource poor environment, X-ray, and you'll be able to then help make the diagnosis from there. And even the way that you show those lines in the diagrams and doing geometry on patients. I know they said you do a lot of woodwork in orthopedics, and so you kind of just demonstrated it over there, Dr. Nevondo. And there's a Kabelo Mapike who is a public sector physio, saying that they haven't come across the condition yet, but basically it's an eye opener and going to approach it, especially from teenagers with hip or thigh pain, quite differently. And I think that's important, is to be able to say have a high level of suspicion, so that when you do that, it's not just about the manipulation of physio, but definitely have a look at it and see what is happening over there. Got a lot of appreciation notes here on the side, Dr. Nevondo. So thank you so very much. Yes, and I told you up front that people are going to be asking for the recording of the session and the presentation. And just so for everybody that is here in attendance, Dr. Nevondo did say he'll make the presentation available. So we'll put it onto our YouTube website, which is the Clinix Health Group webinars. So you'll be able to see the presentation there. You'll be able to see the images and all the research that was done in this regard. So I have a question here for you, Dr. Nevondo.
Yeah.
It says, Manake Mokone says, impressive. However, I wonder why our orthopods are not seen in the studies that informs the present day management. I say this because I believe, as the majority of the population in the whole world, where are our bright sparks, right? So, because we are doing quite well. I mean, you are involved with a large part of this. Is it just that we are not put out there, or are we only going to speak on an international level and our colleagues are being missed? What's happening, Dr. Nevondo?
You know what? Orthopedics in South Africa is actually big. It's big in terms of numbers. It's big in terms of research. It's big in terms of new surgeons that are coming up. There's quite a lot that's happening in orthopedics, and even the presentations are actually a lot. And I think one of the countries in Africa where we have journals in orthopedics, it's in South Africa. We do have that, and even many. If you look at the companies that bring implants and stuff, there are many. So there's a lot that's happening in orthopedics, and it's not only coming from outside, it comes from inside. And there's a lot of our South African or African orthopods that are going out there to present, and they are doing quite great job. And the research part of it is actually very high. I think Mukone, yeah, there's a lot that he can find out. You just need to look out. Like, if I give an example, in the next 2 weeks, there will be the Arthroplasty Congress happening in Cape Town. Last 2 weeks ago, there was a Heart Shoulder Congress, which unfortunately was also in Cape Town. And it was quite a lot of people that you find there, and they are presenting different kind of things. And we just show off one of our bright sparks. One of my friends, who's the head of orthopedics in Steve Biko. He's still like, if he's 40, he's still below 40 or just 40. And he's doing quite great work. So there's a lot happening.
Hmm. That's good to know. I have a question here from Dr. Muhyiddin Khan, saying that basically the reason for higher incidence in dislocation of hip in boys at birth, is it related to pelvic or epiphyseal issues, or is there any other reason why that would take place during that time?
At birth, dislocation, it's not related to SUFE, it's related to Perthes. No, it's related to DDH, sorry, this DDH. And the common patient is usually a firstborn girl. And majority of the time, the reason why they get is the first child is because the mother is still young, the uterus is still very strong, and the child is usually born with a breech. So that child is usually forced out and they dislocate. And what else? Yeah, so it's usually not these children. It's usually not a boy. It's usually a girl, and it's the disease is completely different. It's DTH. It's not SUFE.
So this is Professor Duplessis. He's always contributing every week. So please take this and enjoy it. He says, "Yeah, thanks, Dr. Nevondo. Very informative. Happily, the evidence is fairly low. However, it's a catch-22 situation because one of the causes is that you have an obese child. And then part of the treatment is now you have to immobilize this child, and then you have to keep them immobile while you're actually trying to manage their weight at the same time. How do you approach it?"
Um, Luckily, the treatment is not to immobilize the child. Once you diagnose the disease or you suspect the disease, yes, you immobilize the child so that they don't slip further, so that the patient can be taken for surgical treatment so you can stabilize it. And that should happen sooner. It should be like on the next theater. So within a day or two, they must be pinned. Once they are pinned, the next step is not to immobilize them. The next step is to actually give them crutches and they can mobilize non-weight bearing on the other side. So it's not long immobility. Maybe where you have a problem is a patient where you can't take to theater, they are obese and they have to be treated non-surgical because those are patients you're going to put on traction and keep them immobile for a long period. Yeah, there you will have a problem because now the obesity does not like immobility, but it's very few patients. Majority of the time, you only immobilize before theater. After theater, you get your physio, they need to get out of bed and they start non-weight bearing mobilization.
Yeah, so thank you very much for that clarity. And especially, I'm just thinking in the instance of you said when you do the other side, uh, you know, prophylactically or just as a precaution, then what happens in that case with that patient?
Excuse, I didn't get that one.
You mentioned that you will pin the side where the Sufi has occurred, and then you may do the other side.
Yes.
And the idea is once you've put in these pins on, bilaterally, then are you not then wanting the patient to remain off their feet?
If you're pinning the other hip prophylactically, so it means the hip has not dislocated. There was no
So
SUFE.
you can still
You
use
are
that pin.
pinning it because they are at high risk of uh, dislocating. So you can mobilize those patients after.
Okay. I have a question here from Rasamasha Mokhale saying, you've made the presentation easy to follow. So that's what I was trying to say earlier on. It's just it's technical, complex, but I think it was quite understandable, even when you went into the histology side of things. And then I've got a question here from Mahale Motlante saying that why are endocrinopathies causing SUFI? And the normal hip is that, you were talking about how that's corrected. However, it's further to the question is small children are protected from SUFI by the perichondrial ring that resists shearing force. Is it due to the growth spurt at the hypertrophic area that you showed us? So that's the question.
I think that's the question and the answer at the same time.
Yeah.
So endocrinopathies, they affect your hypertrophic zone on your growth plate. So they actually weaken the hypertrophic zone, and the patient is likely to get a dislocation or a fracture of the physis. And it's happened also the patients in adolescent stage, they're actually at a growth spurt. So their cells are actually very large, and they are likely to actually get injured. So I think the answer is also in the question. It's true. The endocrinopathies affect your physis, which weaken them, and then you get SUFE. And also, patients with hypothyroidism and some other condition, it increases their obesity, which inevitably put them at high risk for SUFE.
Sure. So I've got a question here from Andra Bobape saying, what happens to the surgical fixation as the children grow up, especially when you insert them quite early in their childhood? What happens to the fixation?
Okay. Hopefully you're not inserting them quite early. Majority of the time, the patients you're gonna find, they will be adolescents at the 12, 13, 14 years. So they usually left with about 2 years of growth. So you put the pin, you pin it, and then you wait for the patients to reach skeletal maturity. So where they have no chance of sleeping anymore, then you remove the pin. Even in patients who are young, usually we pin them and leave them until they reach skeletal maturity. So by 16, 17 years, we remove the pin. Question is, even if you don't remove it, usually it doesn't really affect the patients that much, because it's actually in situ, so it doesn't go beyond, it doesn't migrate or anything. But usually by skeletal maturity, we remove the pins.
Yeah, and what happens to this child? Does the child then eventually grow up normal, plays sports, is able to participate in normal activities that children get involved with, or is there always going to be some level of precaution that needs to be taken early on?
Usually the child forget that they actually had this condition.
Yeah.
If it reduces well, it's fixed, and it goes to the growth plate, fuses normally at the right time, then everything goes well. Problem is the ones who were either neglected or there were complications. Then those ones usually will end up with degenerative arthritis and other problems.
Sure. That is it's really remarkable, you know, the fact that you said the primary caregivers, or at least people from the general practitioners, the clinics, and those that are actually making the diagnosis. And unfortunately, not so many patients coming at a later stage with complications of undiagnosed or misdiagnosed SUFE. So that is really encouraging to hear. Did you find the same both in the state as well as in the private sector?
Oh no, it's not the same. In private, literally the diagnosis is done on time. It's early. It's in state. That's where you you do all those other crazy procedures, the modified done and the guns, and because the patients come with the limb that is externally rotated for several months, and yeah, in state the condition is not nice because the presentation is usually delayed, the diagnosis is usually not made. So in state it's a problem, but in private, like I said, once the patient is seen, they usually get an X-ray, and the X-ray get reported. And the radiologist, I think that some of those conditions where, as a radiologist, you are happy to make a diagnosis. You're happy to find, oh, I found a DDH or a SUFE. So they're hardly missed in private, but in state, it's another story.
Sure. Yeah, so how soon after you were talking about the MRI in terms of the value and showing that the the expansion in that growth area. So do you, I mean, how often do you, if you do not pick something up on X-ray, then would you recommend, or if your level of suspicion is high, that you would rather want to do further investigations on these patients?
Yeah, that's like you have to first, once you have a patient with, you suspect it's sulfur, but your X-rays is not conclusive. Now you all your differential diagnosis, they become more important. Like, is it, am I dealing with sulfur or am I dealing with something else? So that's where you probably do bloods, check for infection, you will go and do MRI, look for, is it many other things, because even adding on top of it, it can even be TB, because TB can mimic anything anyway. So
Hmm.
once your diagnosis it's not coming, then you need to do further investigation. And I think the most important one you can do is an MRI, which can give you even those ones that have the pre-sleep or the ones where there's just widened growth plate.
Hmm. Yeah, so you mentioned prior to us starting the presentation this evening that when you were talking about PERDES and DDH, and you said that it can be quite confusing in terms of the picture and the presentation of these patients. So I do think we are going to welcome you back and please ask you to come back and maybe give a bit more context around those and how to approach those, especially in children, because they're not always speaking, right? So they're not always
Right.
saying exactly what the issue is because they're kids and they're running around, they're falling, getting hurt. So one thing is that they're just coming and complaining or being naughty. So yeah, I see you have the image up.
Yeah. I think the DDH might be the one we probably talk about next whenever I get the chance, because it's the reason why the pediatricians go to theater when a child is born is so they can do a thorough examination. And one of the most important tests that they can do on patient is your Barlow test and your Otolani sign, where they
Mm,
either dislocate or reduce the hip, because that tells you the patient's got DDH or doesn't have DDH. And if you miss it and that hip is not reduced, it means the acetabulum will not grow and the complications become very big. So I think, yeah, these conditions, the three of them are important to talk about because they're easy to treat, but if not treated, the complications can be not nice.
yeah, I think you just raised an important question just as we're about to draw to a close, where you said the pediatrician accompanies the obstetrician into theater, the baby is delivered, they make sure that the child is, well, all the APGARs and make sure everything else, and then they're doing a joint assessment and just making sure. So yeah, so I can understand now why the value of facilities or times where you do not have the luxury or the presence of a pediatrician. In that case, what do you recommend?
Hey, I see when I'm looking at the list there, there's a lot of Shankar members. It's it will be important for them to also know some of these examinations, because something like a Barlow and Otolani test, they're very easy to do, like literally very easy. And if you do it once and you find it, you will never really miss it. So I
Mm.
think a lot of education needs to go on to the primary health givers about it. Even the pediatrician, I think a reminder here and there that it's not chest heart examination, it's the whole body. All the
Yeah.
joints must be examined one by one.
Mm. Yeah, no, as you said, it's important to that. And I think the follow-up question to that, and I think it's the last one here, is from Estras Moloko, just being concerned about the fact that there's a discrepancy between the private and the public sector in terms of making that diagnosis. I think you did indicate that sometimes it's actually missed, but I would not say that our radiological or radiology colleagues are less competent. Um, in the public sector than in the private sector. I see the question here is around the competence. But again, feel free to answer that, and you can respond to Moloko.
Yeah, competence maybe, but I think the biggest problem is the load. If you are sitting in an OPD and you're seeing more than 100 patients, it's very difficult that you will actually do an examination on all of them. Some will just be given repeat scripts and stuff, and that's unfortunately the story of our private. The ones who are a bit lucky in private are those that goes to an academic hospital. They are likely to get to it. But I mean, also the terms of numbers in Bara, it's very difficult for anybody to actually do thorough examination on everybody. That's the biggest problem with private.
Can you see the question here by Kelelo Langane?
Yes. Oh yeah.
Mm.
What's the advice regarding Otolani and Balo versus ultrasound of the hip? Ultrasound is an investigation. An investigation is done when you have done an examination. You have to confirm, you have to do an examination. There's no way around doing an examination. An examination has to be done.
Yeah.
When you suspect, then you can go do ultrasound or you can go do whatever is needed to make to confirm the diagnosis. But the diagnosis is usually done by clinical examination confirmed by an investigation.
Yeah. Thank you so very much, Dr. Nevondo. And again, I know you were saying that you did not speak last year and you took issue with that. I'll deal with Dr. Kinoshi is on the line, he assured me. So I'm sure you heard, and you're definitely going to be welcome back. I'm sure all our colleagues that are on the line this evening are going to be asking for you to please come back and do the rest of the topics that you are highlighting on the slide in front of us. So thank you once more. I know it's late, it's raining out there, and it's quite cold, and you're still sitting based at the hospital this very moment so that you can present this to us this evening. So we want to say thank you for taking the time out, presenting it, and making sure that we learn something, and especially something as critical as this that should be relatively simple to get the diagnosis, and yet if it's missed, there could be dire consequences down the line. And I really think you simplified it so that everybody can understand it. I know people are going to applaud you now. You can see it. It's because you deserve it, and we really are appreciative of the time and the effort that you are doing there. And along with your colleagues, we just want to say thank you very much for the work that you are putting in on a daily basis, especially in educating our fellow colleagues, whether it be doctors or nurses or even our OTs and physios and other related disciplines. Again, colleagues, thank you so much for staying up with us this evening. It's like I said, you could be doing anything else, but every Wednesday we receive your support as the Clinix Health Group. And so it makes it ongoingly encouraging for us to ensure that the standard and the quality, as you saw this evening, is maintained and it's quite high. And we really want to say thank you very much to the Clinix Health Group for sponsoring these webinars week in and week out. And again, if there are any queries, we will respond to them in the chat, so we're able to download those. So if there's anybody that requires any information, and even the presentation, please feel free to notify us of that. Again, once more, everyone, thank you very much. Next week, I thought, Dr. Nevondo, we were going to have to skip it because there's a public holiday on the Friday, but we were told that no, we need to make sure the presentations are still running next week. But for those of you that are going to travel, especially because of the holiday being on Monday and the one on Friday, many people are taking off those 3 days in between and traveling. Please be careful on the road. Be cognizant of the fact that we would really love to have you back, and your impact in society is significant. So please look after yourselves, and we look forward to seeing you again here next week, Thursday. So Dr. Nevondo and our colleagues, have a good evening. Thank you so much.